Okay, so hi everyone. Welcome to our monthly critical care medicine section meeting. So we're going to kick off a new series we have this month where one of our members is going to bring to us a relevant critical care paper, give us a little bit of a synopsis, their personal viewpoint, and then we'll kick around the group and see everyone's practice patterns and how it relates to this paper. So we have a really good one for you tonight. All right, the other Dr. Gordon, kick us off.
Hey, thanks, other Dr. Gordon. So the paper that we are going to talk about today is the meta-analysis that came out earlier this year of Etomidate compared to, I guess earlier last year, Etomidate compared to ketamine for induction during rapid sequence intubation, systemic review and meta-analysis in the Indian Journal of Critical Care Medicine in 2022. This was essentially a meta-analysis of what amounted to 9 studies where they looked at the incidence of hypotension during intubation, both in retrospective and prospective, or in trials. They included both retrospective studies, prospective studies, and randomized controlled trials, which we'll discuss in this meta-analysis. And they looked at both first pass success, which was no different between the two groups. And we know that's important from prior studies. And they also looked at the risk of hypotension as defined in that study, the study that they got the data from, and they found a higher risk of hypotension with ketamine. And so that is kind of the meta-analysis. I have some problems with the meta-analysis, and my biggest singular problem with the meta-analysis is that when you put garbage in, you get garbage out. So if you look at least 3 of the trials that they included, including both prospective, both randomized control trials, one is an abstract of an interim analysis of a study. And the second is not even a published study. It's only up on clinical trials where you can get the data, and it was done by Driver, but there's no study. There's no way to evaluate how good any of this stuff that we're looking at is. And one of the retrospective studies was also an abstract. And normally we don't include those kinds of things in a meta-analysis because there's no real way to understand how good or bad that data is and the ins and outs and the details of it. That notwithstanding, I do agree that ketamine is less hemodynamically neutral than Etomidate. And I agree with that, not from my own personal experience, but because we have lots and lots of data that tells us that. So we have the near registry data that was retrospective that came out several years ago that told us ketamine was not as hemodynamically neutral as Etomidate. We have both the Jabra study that indicates that. We have the Keep Pace trial where ketamine was combined with propofol that also hinted at that. And then we have the most recent study that came out, the EVK study, which was semi-randomized. So there are some issues with that show that ketamine was not as hemodynamically neutral as Etomidate. The 2 studies that they cited, one of them, ketamine was not as hemodynamically as neutral. That was the abstract. In the Driver stuff that came from clinical trials, it was pretty similar in terms of the hemodynamics. And that was the only one, if you look at their forest plot, that actually favored ketamine for hemodynamics. But the thing is, for my personal practice, as both an emergency medicine physician and as an intensivist, one of the things that I am really, really, really good at managing, and all of us should be, is hypotension. It's like resuscitation 101. In my first fellowship, it was save the map of 65 all the time. And in this age of resuscitation before intubation, we should never be intubating patients that are hypoxic unless you've done everything and can't get their FiO2 up. I was in that situation the other day. They're hypotensive and you've already started them on pressors and you can't get their blood pressure up. Those are pretty rare scenarios. And the only truly emergent airway that you're going to fix for sure with a tube is the emergent physically threatened airway. Everything else should get resuscitation before you intubate, which means I can both proactively prevent hypotension because I'll have all my meds there, and I will also have everything ready in case my patient does become hypotensive in the moment. But why would that even matter unless there were some other benefit to using ketamine? And I will tell you what it is, because it's logistically, it's impossible, because I have to get it from pharmacy right now, and I usually have to beg an intern to put an order in and beg a nurse to call pharmacy and then beg pharmacy to send it up. And by that time, the patient probably would be ready to be extubated anyway. But ketamine does have an advantage when you look across every single one of those trials that reports mortality. There is a signal of mortality benefit to ketamine over etomidate. And if you combine those from the first three, not from the clinical trials.gov data in RevMan, you will actually find that mortality benefit as a meta-analysis. Now, I don't know why that happens. Obviously, the most obvious reason would be because of adrenal insufficiency caused by etomidate, but we have a Cochrane review that tells us that does not contribute to mortality when compared to Versed and thiopental and propofol. But that signal exists. I don't have an explanation for it yet, but it exists in every single study. And so when I can get ketamine, it is my choice, and I think the right thing to do to get ketamine. And I'm right. I know there's a lot of differing opinions on that.
Well, I guess I'll chime in. That was a great synopsis. I think it's always good to think about which medication is best for the patient in front of me. And I guess my default, I'll be honest, is ketamine. We have it in our airway boxes. I can get it like that, along with etomidate, unless there's a shortage. And I use etomidate more selectively. Me personally, I take care of some sick cardiac patients. You know, for instance, I had somebody with a depressed EF and severe aortic stenosis and cardiogenic shock after an acute MI. I don't want the blood pressure, the heart rate, the myocardial oxygen demand to change at all. In that case, I'm using etomidate in those sick patients. Otherwise, I do like ketamine. I think it's a great drug. I think you can adjust the dose to prevent hypotension in your really sick patients and start pressors ahead of time. And as you said, David, resuscitate ahead of time. But I will say there's still a use of etomidate. The mortality associated with it is just that, an association. It's unclear which patients that may be real or not. So I don't get hung up on it too much. If I think it's the best drug for the patient in front of me, I still use etomidate.
So I have a question. If our argument is about it being hemodynamically neutral, I think probably one of the most hemodynamically neutral drugs I use to chill patients out, right, not an antipsychotic, is Versed. And Versed's like really hemodynamically neutral. It's I use it in all my patients that I intubate with ROC. They get 2 milligrams of Versed right after the tube goes in. They get Versed while I'm, just because the propofol is going to take time to work. So why don't we use Versed outside of the data regarding Versed drips, right? And the context-dependent half-life and the issues with delirium. But we're not talking about a drip. We're talking about a push, which has never been shown to have those issues.
Well, probably it also depends on practice cultures, and a lot of times where you practice, there's always a culture and habit. Unbeknownst, my shop actually likes Versed, so I do use it more often just because it's more comfortable with what the surgeons use, because I work in the CT ICU. So sometimes I do have to like bend towards the whims of what they prefer. Of course, if I have a choice, ketamine etomidate is usually my go-to, but like what Skylar mentioned, sometimes if the fear of hemodynamic change is present for certain like aortic stenosis patients that have HOCM, or their risk of, you don't want them to get tachycardic, you want to make sure that their heart rate is controlled, then you might not be able to reach for ketamine because they might even want to consider that. So in those patients, then etomidate Versed would be the choice that we use if we had to intubate those kind of patients.
So there's actually OR data about this, about using etomidate. I was in the process of collecting a lot of these studies anyway. There is OR data about this that I'm pretty sure shows that etomidate causes tachycardia, or is more likely to have tachycardia than ketamine. Like, we can manage whatever hemodynamic things happen. And if there's a bigger picture, right, the bigger picture at the end of the day is still going to be what happens to my patient in a week, in a month, right? And I don't think I'm making up this signal that exists repeatedly in every single, it's not like it's like one way in some studies and another way in another. In every prospective study, it's there. And I don't know that you can just, at a certain point, you have to ask yourself, like, okay, is it a real thing?
Right. So I don't disagree with that, because if you're saying ketamine, supposedly in the doses that we use, the hemodynamic changes might not even be significant anyways, because it's what's the sympathetic discharge from your patient. They might not even have that reserve to begin with to cause that tachycardia and all those changes you expect, hypertension with the ketamine. So sometimes the patient will have their own hemodynamic changes and heart rate changes regardless of what agent you use. And that's why in actually my practice, I reach for the one that I'm comfortable with, what fits everyone's comfortability, because at the end of the day, like you said, there are a lot of things that we can manipulate to augment their hypotension, their tachycardia, or anything if I needed to as well. But I mean, people still have a preference, and I would still argue that if people have a comfortability about using certain agents, they should use the agents that they're comfortable with, because if they're not comfortable with other agents, then why use it? Because you don't know what the side effects or the interactions are.
So if you were going to open an ICU tomorrow, an ICU and ED tomorrow, and they said you can have one RSI drug, you can have a drug for every indication, but you can have one drug for RSI. Which one are you choosing?
You'll probably use ketamine still. Just
Skylar?
because.
One drug, ketamine. Yep.
June?
I'm an etomidate person.
Really? Okay. Why?
Yeah. Because I like predictability. And because I'm used to it, I'm comfortable dosing it. I'm comfortable dose adjusting it. And I like knowing what's going to happen. And I have a hard time believing that I'm not getting something from using ketamine. I hear you about this signal for benefit, but you have to explain to me where that's coming from in a way that makes sense.
Yeah.
And I believe what Cochrane says, that I'm not hurting patients. And so for me, it's predictable and I'm comfortable with it. And so for me, that's my one drug. Sorry.
Great.
Yeah, I'm gonna be on Team Etomidate here. This is certainly a drug that I think I agree, is very predictable. I also happen to work in a state, which is the glorious state of New York, where ketamine is considered an anesthetic and can't be pushed by anyone except a physician. So it does create a little bit of a logistic hurdle when I have a laryngoscope in one hand and a ketamine syringe in the other. It's doable. I've done it, but it does create that logistic problem. But even if I work somewhere else in a different state, I even still reach for Etomidate in the sense that I don't have to worry about the complications that come afterwards. I don't have to worry about, is this patient going to get super hypertensive, which I've seen with ketamine, or is this patient going to crash on me immediately afterwards? I've also seen with ketamine. It creates a very hemodynamically neutral situation. There, definitely the mortality is something that I agree. It keeps cropping up and is certainly very concerning. At the same time, it continues not to. I continue to wonder: is this really the problem of multivariate analysis? If we keep looking and measuring variables, do we keep finding something? Are we just going to keep? We keep finding heads come up on the coin. Is the coin weighted, or is it we just have flipped the coin enough times? I don't know. And I'll just say, at least it doesn't seem to jive with the anecdotal experience of. It doesn't really seem to matter whether I get Etomidate or ketamine. The survival outcome doesn't really seem to make that much of a difference. What we see on everyday clinical practice.
You or Fred?
Yeah, I mean, I'm still on Team Etomidate. That I think for so long, people gave up the association with the adrenal insufficiency. It totally happens, but that's not what leads to mortality. I think the same thing, that I think there's some intervention bias in personal practice. Because even thinking ketamine again, like there's actually direct myocardial depressive effects there. Sometimes the tachycardia, you can't judge how much it's going to drop. I think also I think my big issue with the meta-analysis and most of the studies, it's all pre-hospital and ER data. And if I'm walking in a room and there's a blue person, is very different if I'm like pontificating in the ICU with an A line, messing around with flow track or a swan, and I can kind of see what's happening in real time. And I think there's also a real intervention benefit of like when you're with trainees and residents, depending on the level, their comfort level and knowing what to expect and happen, I think makes a big difference as soon as I walk out. And then somebody doesn't realize the heart rate's no longer 130 and their cardiac index totally tanks. So I think undifferentiated, I would go Etomidate. And I actually go mostly Etomidate and rock these days, unless I think it's going to be a difficult airway. And then I'll actually do like some ketamine and that's it. Versus I actually did train with anesthesiologists and surgeons. So I think personal practice I picked up for my like kind of unresponsive, minimally responsive patients that probably don't know. I actually will do fentanyl Versed and sucks or fentanyl Versed and rock. Just because again, like it's more probably treating me than them. I just feel bad not giving them something for sedation. But to be honest, they're so unaware that I'm not sure that they really know anyway. So I'll give 2 of Versed, 50 fentanyl, push them paralytic and put the tube in. But I still mostly go, again, it takes me a long time to get ketamine. So by the time I could actually get ketamine, they're probably like pushing me away and going home. But if I had to just pick one drug, I go Etomidate.
So
I do think it's important for if there's non-intensivists or even intensivists who watch this, I usually don't use full RSI dosing of my Etomidate. I think that is important to note. I very rarely give the full 20 to 30. I actually never give more than 20 because a vial for us is 20, but I almost never give 20. So I think that's important too.
do you change it based on the hemodynamics?
Mental status first, right? Like how much is it going to take? But yes, if someone's more tenuous, I'll give them less often. But you know, the reality is all of our patients are tenuous, so.
All right, so we have a 3-3 ketamine versus Etomidate. If we're starting a shop right now today and can only have one drug for RSI, unless you want to chime in, Kathy. But the thing that we all agree on, right, is that I think should probably be put to bed, but we keep having this discussion, is that ketamine is probably not truly hemodynamically neutral, even if it's more hemodynamically neutral than other stuff we used in the past. But definitely compared to Etomidate, it's not.
Yeah, I agree. I think even when Ketamine came out and then everybody was jumping on the ketamine push for everybody, never get hypotension train. I think it also was so much patient selection too, right? Like I think in the beginning, people didn't think about if you're trying to intubate somebody that's already tachy to 140, you can push all the ketamine in the world and their pressure is going to drop because they can't get any more tachy. And if they do, you're already in trouble and you should probably pucker a little bit anyway.
As I say, use the drug that matches your patient. You know, might be Versed, it might be ketamine, it might be Etomidate, it might be propofol. I use all of them. And maybe it's just the nerd in me that enjoys to think about this a little bit and at least think about what might be best. Although I might just be making it up and it probably doesn't matter in the patient you prepare for the procedure. But I still like to think about this and I use all of those medications regularly.
I would say another thing that's changed in my practice after I did ICU fellowship is I'll often combine drugs, which is something I never did in my emergency medicine residency. I think, I learned that from training with anesthesiologists who will, create a cocktail, and I like that very much. We also have a big neuro population, and so I will often or always ask in the room, do you want more blood pressure or less blood pressure? Along the lines of, Skylar's thought, what's the right drug for the patient in front of you? So that's something I'm always thinking about, is which is more risky for this patient, more or less.
Do you push fentanyl for your neuro patients?
Not always, but depending on the patient.
Fred,
Yeah,
you said,
Yeah, NeuroCrit, that actually the one I use more more ketamine and more fentanyl for those patients, like the really bad TBIs. Because often a lot of times you're just waiting for kind of airway protection. So I'll actually like try to wait, push the fentanyl, wait a few minutes, and then give the ketamine. And I've had a lot of NeuroCrit people kind of arguing these days that that's the right way to go. So for a lot of the neuro and the traumas, based off of obviously old paper and data in the 80s, but I'll actually do more for the neuro TBI folks with fentanyl and ketamine.
Yeah,
And
I use fentanyl for my neuro patients.
I echo Skylar too. So I know you were trying to create the perfect scenario where you can choose one RSI drug, but if you have all of those in your repertoire, why limit yourself to only one drug when you can actually see which one works best? And like June said, sometimes the cocktail works better. Like you mix a little bit and you can kind of negate some of the hemodynamic effects of one versus the other. And you never know. So as long as you're familiar with the drug and what kind of effects it can cause, then use whatever you can and base it on the patient. And like if we work in the ICUs with surgeons, their preference always come to mine as well. So you can't just use something without them consenting to it because it is their patient. So that also comes into a factor as well.
Okay, wise as always. So thank you so much, Dr. Gordon. This was excellent. Tune back in next month. We'll have another topic. You have any closing remarks for us?
No, I think that was an awesome discussion, and I think a lot on everyone's side to think about. I don't know that my mind has changed, but I think everyone made good points.
I can't imagine changing your mind about anything. But thank you.